This time I'd like to do roll call for our committee members. Deborah Davis. I believe she's having trouble getting in. We'll resend her a link. Dr. James Doddington from Yale New Haven Hospital.
Present. Good morning.
Good morning. Ebony Epps from Wrapup, Street Safe, Bridgeport. Dr. Kyle Fisher from the Javi.
Present. Good morning.
Good morning. Leonard Jihad from Connecticut Violence Intervention Program. Dr. Charles Jandro, Hartford Hospital. He's just happening.
We just admitted him.
Yeah. Dr. Charles Jandro, Hartford Hospital. Okay. Mike Makowski, Department of Public Health Injury and Violence Surveillance Unit.
Here.
Welcome. Jacqueline Santiago, Compass Youth Collaborative. Carl Schissel, Connecticut Hospital Association.
Good morning, present.
Good morning. Dr. David Shapiro, St. Francis Hospital.
Good morning.
Good morning. Dawn Spearman, you are not alone. Jeremy Stein, Connecticut Against Gun Violence.
Good morning, everyone.
Good morning. Colleen Violetti, Department of Public Health, Injury and Violence Surveillance Unit. And Chairman Andrew Woods, Hartford Communities That Care.
Present.
Welcome. At this time, I'd like to bring up the minutes and for approval. TJ, if you can give me the screen, I'll pop them up here. Is everyone able to see them?
Not yet.
No. Let's see. Are you
There we
able
go.
to- All right, perfect. Thank you. Please let me know if I missed anyone and your name needs to be added that you were present. The action items that we had were promotion of the public hearing and public safety hearings that Chairman Woods will give us some reflections on that took place on November 17th. We talked about restructuring of the subcommittee and work groups and their makeup. And we went from the 4 committees to these 3 here, the community engagement and public health work groups that were co-leads are Deborah Davis from Mothers United Against Violence and Michael Makowski from the Department of Public Health, with members Ebony Epps from Wrapup and Street Safe, Dawn Spearman, You Are Not Alone, and Jackie Santiago, Compass Youth Collaborative. The policy and funding work groups, the tri-chairs as Carl Schissel from Connecticut Hospital Association, Jeremy Stein from Connecticut Against Gun Violence, and Jackie Santiago from Compass Youth Collaborative. And then the third committee is Evidence-Based Programming and Research Work Group, with the co-leads for Dr. James Doddington from Yale New Haven Hospital and Dr. Kyle Fisher from the Javi, with member Leonard Jihad from Connecticut Violence Intervention Program.
Okay.
And we had our future meetings were listed here, as well as our 3 great presenters from last week, Ashwad Thomas, Greg Jackson, and Dr. Kyle Fisher. And announcements that we had were to identify community members and public safety officials to provide testimonies for the upcoming hearings and compiling documents for final report and request for chairman and administrator Violano to be present at all work group meetings. And we adjourned the meeting at 3:11 p.m. Do I have a motion to accept the minutes as is?
I'll move.
Who is that?
Jeremy.
Jeremy, thank you. And Jeremy, second?
I'll
Did
second
Dr.
it.
Shapiro? Okay, thank you, Michael. And I'll turn it over to Chairman Woods.
Okay, thank you very much, Pina, and welcome everyone to our advisory members, but also to those that may be watching on Facebook or CTN Live. Thank you, CTN, also for covering this hearing, or this, last week was the hearing, this committee meeting, and we're looking forward to a robust discussion today on the work that's already been compiled by our committee members. Special acknowledgements. I know that Senator Moore is in the wings. She'll be watching from home, and may or may not be able to weigh in on any of the conversation, but she's certainly looking forward to the report out from any of our committees. I don't believe there are any other special acknowledgements for today. Peanut, related to the folks, the reflections for the public hearing last week, I think in summary, I believe we certainly had a very good turnout and had a lot of folks that testified, very impressed with the range of ideas, the range of passion, the range of interest in supporting this work of not only the commission, but also really elevating the importance of us addressing this issue in our state. Pina, what was that number last week in terms of those that testified as well as those who submitted testimony?
Perfect. Thank you, Andrew. We had a total of 47 individuals that provided testimony on the 17th, as well as 24 written testimonies that were submitted. And from the 5th public hearing, we had 14 individuals that testified, with 3 individuals submitting written testimony. So very well representation on both.
Okay, great. From our members, any reflections from any of our advisory members from last week's presentations or testimony?
This is Mike. I'll bring up what I heard from Damari in the folks in Hartford area. That what really struck me was people are self-medicating with marijuana in those areas, and I'm very curious in other areas of the state, particularly where there's a lot of trauma and lots of violence, if those folks are self-medicating with marijuana.
Thank you, Mike. Anyone else?
I thought a common theme that we noticed was that just a need for some structure in the state, which is universal everywhere. There are lots of people doing really great things, but making sure that everyone works together as a team, and there's some centralized power to bring people together and make sure funding gets out and everyone's taken care of is really important. And I'm hoping that Jeremy's going to be talking about that today.
If I may, I'd like to echo that statement. I think you hit it right on the nose, is that lots of people are advocating for their own organizations on these calls and on the public hearing. And what we have to do is come together instead of just creating another organization or another effort in one town or in one place or in one process, to really come together and work on this preventative and important public health measure as an undivided unit. Thanks for that, Kyle.
Jeremy.
Yeah, I think that I guess what impressed me most was the number of people that testified and the different groups that also testified. I can't remember ever seeing that many groups at any type of public hearing at the General Assembly
And so it was incredible to see so many people that are doing the work, the boots on the ground work, to come and tell us about their organizations. And I think this is really important to continue to do, that we continue to hear from these organizations, so we can learn more about what they're doing. And I know there's many other organizations out there that are doing this type of work that did not testify.
Okay. All right.
Andrew,
Yes.
hi, I just wanted to add, this is Deborah, and I'll put my video on.
Hey, Deborah.
Hi, how are you? I
Good,
just
good.
wanted to add that the importance of listening to people, boots on the ground, bottom up in terms of the conversation, I think is really key for us as a group, because I believe that it has more value than people would think. And if we plan to be effective and efficient, we have to start where the work begins. And so I was certainly too impressed by all the organizations across the state as well. But I think that is something that we have to keep in mind as a commission, and looking at this entire this entire paradigm, if you will, from the bottom up, and understanding the specific needs of folks across the board.
Thanks, Deb. Hey. Other reflections? Going once, going twice. All right. Well, thanks everyone for those reflections. And at this time, we're going to move on actually to a few announcements, and then we're going to get right into our presentations today. Announcement number one, that for all of the work groups, your written final findings of your subcommittee work groups are due to Dr. Pina Violano by Friday, December 3rd by 3 p.m. The first draft of the executive report will be presented at our next advisory committee meeting, which is Friday, December 10th from 11:30 to 1 p.m. And then the final draft report to be presented to the advisory committee Wednesday, December 22nd. And please note, advisory committee members are required to vote on that executive committee report. And then, of course, as a final reminder, the executive report is due to the state legislature on January 1, 2022. Today, for our listeners, as well as certainly our members are aware of this, that our main emphasis of our agenda today is focused on our 3 work groups, of which each will be presenting their draft findings with recommendations, followed by questions or additional input from each of our members to be included in the additional revisions to what they'll be presenting today. And so our 3 work groups presenting is the evidence-based programming and research work group, our policy and funding work group, and our community engagement and public health work group. And so again, each work group will present their initial findings and their initial recommendations, and then go back to the table to make any additional revisions that will be submitted to us in draft form by Friday, the December 3rd. And so we'll be starting out today with co-leads, Dr. James Doddington and Dr. Kyle Fisher, with member Leonard Jihad, and this is the evidence-based program and research work group. And so I believe, Kyle, you may have ability, you and James, to share your screen. Thanks. Great.
All right. Thank you very much. Dr. Doddington's going to kick it off. We appreciate the chance to be here.
Hi, folks. So we are going to do a bit of an overview here. Given that we are trying to limit our time to a 30-minute block, please understand that we are going to kind of take a pretty high-level overview of the approaches. And then at the end, we'd like to hold some time for some discussion among the committee members on kind of both inclusions and questions and where we should go in terms of further report. So just an important caveat, just very quickly listed here, many of the evidence-based approaches that are out there in terms of violence intervention and prevention, hospital-based violence intervention program, lots about, either cure violence, street outreach / violence interruption, which we'll speak to, targeted trauma-informed care, including the application of cognitive behavioral therapy, survival and family assistance programs, peace fellowships, and place-based organizations, inclusive of kind of gun violence intervention, prevention events. So Kyle, will jump one ahead here, just a very important opening caveat. So for many of these approaches, there is limited published evidence. However, this is not indicative of failure of that approach in the community or otherwise. More often, it is indicative of a lack of funding and resources for full evaluation. And I think importantly, we all heard very eloquent comments on this issue during our hearing in the last week, in which evidence-based needs to be carefully examined in the context of what kind of evidence was able to be applied, and then of course evidence-informed methods of both intervention and prevention. Many of these approaches need to be seen within, and I take this directly from Fatima Lauren Dreyer at the Javi, the ecosystem of programs. So you can see here the overlap pieces of hospital-based violence intervention, outreach, GVI, peace fellowships. My apologies, I might have missed GVI in our opening there, but we will speak directly to it. So Kyle is going to take over now and do a quick run through hospital-based violence intervention.
Thanks, Jim. For all of these programs, we tried to take a pretty uniform approach to showing you what it is. So it's one slide for what it is, and a lot of them have multiple names, so we listed that as well as some existing programs in the state. Also, caveat that there's so much work going on that I'm sure that we have not listed some people in some of the categories. So if we haven't included a name or a program, it's not saying that we don't believe in it, or it's just there's so many programs. And then the next slide is the evidence what they're about, and then the evidence for how they work. So all of the interventions, same format. So hospital-based violence intervention programs, sometimes called hospital-linked violence intervention or hybrid hospital programs. Here in Connecticut, there's the Connecticut HVIP Collaborative with Hartford's Community That Care at St. Francis, Yale New Haven, Bridgeport, RISAP, and others are emerging. So the HVIP program model is fairly simple. The idea is that when someone comes into the hospital or after they've been injured, that is a marker that this is a high-risk person that needs assistance so they don't get injured again, they don't injure someone else in retaliatory violence. And we know that they'll have that trauma that we talked about in the last meeting. So after an injury, the person is seen as soon as possible, either at the hospital bedside or shortly after discharge, if say they were discharged from the emergency department, with a violence prevention professional. And at that time, you do the immediate crisis intervention. What's going on right now? Is there any retaliation? Is there anything that we need to do right now in these hours or days to prevent further violence from happening? We ensure that in the second level, the patient gets all the medical care that they need. And that means both physical care and psychological. So starting to build that relationship with the patient in the frontline violence prevention professional so that they can set the seeds for that longitudinal trauma-informed care, so they can do pure mentorship and engage in mental health in a culturally competent way that isn't, the health system telling people, yes, you need to go see a psychologist or something like that, because we know that doesn't happen.
Yes, we could, is it the right way of doing it?
And then after that, that care plan, there's a long needs assessment that takes place, and the hospital violence intervention program works with the patients for 6 months to a year, or however long they need, to make sure that all of those medical needs, social needs, case management needs are addressed in the social determinants of health, things like education, jobs, insurance, anything someone needs to recover, that all happens. Does it work? So there are 3 randomized controlled trials for this, and this is looking at re-injury. And you can see in the orange what happens if you don't do anything after someone's been violently injured and hospitalized. In the one trial in Baltimore, 36% of people in the control group were injured. In Chicago, 20% were re-injured, and in Virginia, 6.2%. And we're seeing in the intervention groups, people that got HVIPs, between 5 and 8% were re-injured. So pretty big decreases there. Since then, and I include this trial because I think it's really helpful for thinking about all of these interventions today. If you look down at the green box, that is a summary of what happens if you don't do anything for someone that's been violently injured. You know, you discharge them to the street and hope for the best. And the average, this is a combination of 19 different trials. The average rate of re-injury was about 27%. So if you don't do anything after someone gets shot, 1 in 4 is going to be re-injured. The best case scenario they found in the lowest, the best of the 19 was 7%. So either way, that is a high risk of people getting re-injured. So when you look at this in terms of some of these other hospital-based violence intervention programs, in the Bell, Juilliard, and Smith trials, they were at about 4 or 5% re-injury. So better than the lowest of the low in the review of doing nothing. So pretty solid evidence that this works. And I mainly included this extra piece of evidence so that we can think about, for all the different interventions today, what happens in these high-risk people if you do nothing. And the best case scenario is about 7 or 8% of those folks will be re-injured. And on average, at least 1 in 4, 1 or 3 will be as well. All right. And then I think, Jim, you were going to make some notes here.
Just a comment for this group, I think importantly to understand the local context. Kyle, thank you so much for this national view, and we're going to continue to lean on your expertise. That our current programs in existence in HVIPs are primarily hybrid or community link programs at this time, and Chairman Woods can comment if he likes. Our question section, that these are hybridized, meaning that hospitals have buy-in and partnership, but the programs are primarily community-based programs that may be doing some degree of violence interruption, CBT, physical and mental health outreach in combination with hospitals. So it's an important note, and Kyle did mention that at the beginning. And we have to understand that many of these interventions exist essentially in a blend of a few different things we're talking about, which leads, I believe, to our next topic as we go to the next slide. So I want to make the opening statement that street outreach violence interruption exists in many different forms. One name that is commonly known and probably the most evaluated version is a cure violence model. Gary Slutkin and others that originated this model. There are these kinds of programs existing in our states, such as CTVIP, Compass Youth Collaborative, RISTAP, Street Safe, all represented well in this call. I know our friend Leonard Jihad is here with us today. And is on our committee. The general concept here is you are going to interrupt the violence. So finding folks that are particularly at risk, particularly youth, and who are folks who can be engaged by jurors, and that you can reduce episodes of violence downstream. So looking not in the HVIP model at folks who've been injured, but looking upstream at folks who are at risk. Maybe they've had an injury, maybe not. But you can imagine there's great synergy and incorporation of having both HVIP and violence interruption work being done in a synergistic way. We know that there are evidence from the cure violence model that these programs can work, and Kyle will go to that here. So there is an evaluation by John Jay College in New York City showing a reduction in shooting episodes as well as reductions in Philadelphia. There have been international evidence-based versions of cure violence that have definitely shown some substantial impacts if done throughout entire regions. Importantly, and I think for us to think about in the state of Connecticut, is that the cure violence model, I think is helpful, but many of the programs that I listed, and I think our representatives from Compass and from CTVIP can speak to the fact they're not just doing this interruption work. Oftentimes they're providing trauma-informed care. In addition to trauma-informed care, they may be providing some CBT. So all of these things may be in combination and we're seeing them. So unless folks want to further add to that, I can pause there as I hand back over to Kyle, but we can definitely take some comments on this at the end.
All right. So our next intervention is called group violence intervention, also known as gun violence reduction strategy, focused deterrence. Like we said, we got to say all the names because otherwise it gets very confusing. Project Longevity is the most famous and prominent program here in Connecticut. GVI is probably one of the most well-studied law enforcement-based program, and there's a lot of literature out of the criminology research, with the usual caveat that there is a spectrum of, how much law enforcement leads versus, partners with. But the idea is that it focuses on high-risk groups of individuals. So the law enforcement officers identify groups. They partner with various sectors of society, such as social services, faith groups, et cetera, that they know that there may be violence between the groups or with the groups. And so they identify those individuals and they do what's called a call-in to demand peace. So usually bring in either a faith leader or prominent members that the folks in some of these groups might would be respected. And then there's a demand for peace. And the idea is law enforcement say, hey, we're here to help you. We want this to get better. We have all of these groups that are here to help. We can help with the social services. We can help with insurance and food and how, whatever you need to help to get off this path. But if the violence continues, you will be held accountable, is kind of the, carrots and sticks model for this. Like I said, this is really, really well studied in the criminology research. What you'll see here is a graph, and if you look at all those boxes, anything to the right of 0 is something that is likely to be effective. And lots of evaluations, and there's a lot of consensus in the criminology field that this is an approach that works. And without getting more into the nitty gritty of this, like all research, it's complicated, but the consensus view is that this is a evidence-based approach. All right. So next up is something that, we're calling targeted trauma-informed care, which is really kind of a umbrella term for organizations that focus on individuals that have been injured or been exposed to trauma, which is most patients that have been violently injured or are at risk of violent injury, and do some combination of mental health therapy, usually cognitive behavioral therapy, as well as peer mentorship and things like that. So there are a number of examples. There's a group called Ready Chicago, CRED Chicago. ROCA is a program that is in Boston and Baltimore that has been around for a while. I'm told that they've moved to Connecticut recently as well. And so in Connecticut, there's Hartford Communities That Care does a replication of the Becoming a Man program from Chicago that I'm going to cover in a moment. There are lots of different providers like clinical social workers that are doing CBT throughout the state. And then there's the Connecticut Center for Nonviolence that either fits in here or maybe in a different category as well, but they kind of were a hybrid and we were having trouble figuring out what category to put them in. So the idea of these is, like I said, do this relentless outreach to try to get at folks that are at high risk, but maybe hard to get at. So you have credible messengers and outreach workers that actively seek out these people, whether or not be referrals from the medical system or the justice system, any number of places. do the cognitive behavioral therapy, and then do those other things like peer mentorship, support services, skills buildings, and jobs. And for the evidence base, probably the best evidence for this, and there's a lot of it, there's evaluations of all these different individual programs, but like I mentioned before, there's a program out of Chicago called Becoming a Man that is a very focused cognitive behavioral therapy program that this is from the National Bureau of Economic Research. So like the cream of the crop of economists. And what they found, and I'm just going to read this because for any of you that have read papers from economists, there's too many very complicated formulas and stuff, and the graphs are not very pleasant to the eye. But in the 2 studies participation in the program, they reduced total arrests during the intervention period by 28 to 35%, reduced violent crime arrests by 45 to 50%, improved school engagement in the first study where they had follow-up data, increased graduation rates by 12 to 19%. Then the third RCT carried out with the Cook County Juvenile Temporary Detention Center reduced readmission rates to the facility by 21%. And these large behavioral responses combined with modest program costs implied a benefit cost ratio for these interventions from 5 to 1 up to 30 to 1, right? So that's $5 on the dollar, at best $30 on the dollar. So this is a great intervention. There's strong evidence to support it. And like we kind of alluded to before, this is something that can really be included with all of the models we mentioned today. So, all right, next step. And I know we're going real quick, but there's just so many things that we got to cover. So the caveat that, you know, all of this will be written out in long form in the written summary with all of the citations, all that. So next is survivor and family assistance. We got a good overview of this from Mr. Aswad Thomas from Survivors for Alliance for Safety and Justice, or Crime Survivors for Justice. Examples here are trauma recovery centers and Mothers United Against Violence that are here in Connecticut. These programs focus on really anyone that has been a survivor of violence of any form. So either physical violence, sexual violence, abuse, neglect, and it focuses on both those physical and psychological wounds. So I hope you all are catching a theme here. And then it provides comprehensive treatment with multidisciplinary teams to provide trauma-informed care. So a lot of the same things that we've had. And the trauma recovery centers, when they describe their model, they have 10 core components. I've listed that on the right side. So it's outreach, serving survivors of all types of violence, comprehensive services, a multidisciplinary team, coordinated care tailored to individual needs, case management, inclusive of complex problems, use of trauma-informed practices, being goal-driven, and being accountable to the patients. So, you know, again, very similar, you know, we're seeing a lot of these really important things of taking care of physical wounds, taking care of psychological wounds, making sure that it is a comprehensive team-based approach, and that we're delivering all the services patients need to fully recover. They have found that in their programs that clients are twice as likely to receive mental health treatment and increase linkage to social services and increase access to crime victims' compensation benefits. So a very important benefit for those individuals that have survived violence. All right, Jim, back to you.
So we're going to get close to the end here, and we're hoping we have enough time for some questions and discussion. So I'm going to move very briefly through a massive part of really environmental improvements. We actually had a great meeting yesterday in the New Haven Violence Intervention Prevention Committee with Jeremy Stein and others to talk about some of these interventions. So as folks might have heard and seen in media, there is a resurgence of interest in green space or building rehabilitation as a method of violence prevention. Some folks may be aware of a recent, very popular New York Times piece by Dr. Gina South, who is a epidemiologist and researcher at Penn, alongside Dr. Charlie Branis, who's a longtime spatial epidemiologist who've looked at direct impacts of greening areas and building rehabilitation in Philadelphia and New Orleans, and have shown substantial reductions in gun violence, upwards in the quoted article of Dr. South in her academic article of 20 to 30% in reductions in shootings in the areas where interventions were made. There is a long history of place-based interventions, understanding better the physicality of both the shading and green areas, as well as proximity to alcohol outlets and things like this in terms of mediating gun violence. And then in addition, I want to make sure that we note some of the not necessarily place-based, but event kind of aspect of gun safety initiatives, like the recent statewide gun safety program, in which there was a gun buyback paired with a gun safety event. We know that these are not traditional human kind of intervention of trying to individual-based interventions for gun violence prevention, but they do have some impact. And I do want to make a kind of a linked reference to the fact that we know that some of the community garden efforts that are part of green space interventions are also linked to the efforts of groups like Swords to Plowshares that are creating garden tools out of the weapons that are procured from gun buyback and gun safety events. And that kind of linkage can have long-term impacts. We had a great talk yesterday by Dr. Chris Morrison, who works with the two other authors I mentioned, who pointed out that the evidence for these green space and community interventions is strong. It is also very likely to have long-term impact in the environment. So just want to make sure that that is on the radar for folks. And Kyle, we can keep moving forward there. Do you want to briefly mention just our overview of funding?
Oh, yeah, I think, you know, we kind of covered this before, and I know Jeremy is kind of is going to get into this, but, you know, we've got a list of a lot of the different ways that this can be funded. You know, a lot of the hustle-based and anything involving cognitive behavioral therapy or therapeutic services could be covered under Medicaid. The Victims of Crime Assistance Program provides grants for anyone that is a victim services provider, which is essentially all of these programs. The Burn Justice Assistance Grant Program is a federal grant program that has traditionally gone towards law enforcement based strategies, but recent clarifications from the federal government has made it very clear that it can more broadly go to just about any violence prevention strategy. There's 26 different federal and state grant programs that I covered in the presentation earlier. And then depending on what happens in the United States Congress, a bill passed the House just last week, the President's Build Back Better bill, that provides $5 billion in a dedicated community violence intervention funding streams. Odds are that this will likely pass the Senate, but you know, I don't count on Congress for anything until a bill gets signed by the president, so to be determined.
Our final comment, we were asked to just make note of programs in which there may not only be a lack of evidence, but there may in fact be detrimental effect. So I want to be very careful here. I've highlighted just two programs here in kind of earnest. And the second program, the third I'd like to have for open discussion. One issue is there is published evidence that fear-based programming, such as a Scared Straight, where you are trying to kind of scare particularly youth offenders into non-further offense, are not only known to induce further trauma for the participants, but are also known to be non-effective. So we just want to make sure that that's clear from a recommendation standpoint, and there is published evidence to this fact. The other issue that came up yesterday that I wanted to make note of, as we've talked with our law enforcement partners on all these issues, is that as green space intervention and rehabilitation is coming back into vogue, and there is really, I think, great evidence for it, we want to be careful that that's not being seen as paired with a broken windows law enforcement, in which that same green space that's improved in communities is then highly policed and or over policed of course, fracturing relationships and leading to untoward outcomes. The other and final piece, which I really think segues well into really the conclusion of our discussion and opening it up to the group, is that mentoring programs that are pure youth development programs and not necessarily paired with a clear outcome-based measure and or with a violence intervention or prevention strategy probably do not have as much impact, not necessarily detrimental effect. And we do need to be cautious that as potentially more funding is opened in this arena, that the programs that are being built have structure and have an evaluation pathway. So we want to end there, really opening it up to the group. Specifically, Kyle, I think as we pause and sharing our screen, whether folks have some questions, both for our presentation and recommendations for further additions to our document.
Hey, Jim and Kyle, thanks for the presentation. At this time, we'll open it up for questions and comments. Mike.
Great presentation. I have a question. I previously served on a planning and zoning commission, so I'm very interested in land use and how it would work in preventing violence. So is green space pretty much setting up like parks or areas of refuge, if you will?
It's an important question, Mike, and honestly, a lot of this is recently published. We were just asking the same question of some experts yesterday. He commented that as opposed to necessarily full creation of parks or new space, a lot of the work that's being done is in smaller scale rehabilitation of vacant lots or dilapidated buildings within areas that have high levels of community violence. So as opposed to necessarily one large park, many areas of rehabilitation may be the most effective, and at least were the ones studied by Dr. South and Dr. Brannis, and they're ongoing in New Orleans and a recently published piece in Philadelphia too.
Thank you.
Hey, any others? Okay, go, Pina.
And thank you, Jim and Kyle. Absolutely outstanding presentation. Question I have for you. So swords to plowshares programs, where do you see them fitting into the green spaces? And is there any kind of metrics or things that we could use to help showcase, like, again, that kind of work and adding in where there's community participatory, maybe research that could take place with that as well?
Yeah, I would comment and really link this, Pina, to our comments at the beginning of this session that as we talked yesterday in a smaller group, that some of these green space initiatives and other aspects of it may be a nice uniting force for larger groups to come together, both in terms of the multitudinous programs that don't necessarily always overlap, and in a group like Swords to Plowshares that then can also focus on the gardening aspect of it, which I think is understudied and probably could be used more in a lot of these initiatives. That was the focus of some of the work of Dr. South. Not to make our presentation overly on this topic, but I do think it's a unifying project. And I know Leonard Jihad and others have seen that in some of his work. So definitely a point where a lot more could be done as a collaborative group.
Yeah.
Oh, sorry.
I'll just add, Pina, and then you can jump in. I think that, the gun buyback idea is one that really does seem to fit best in this idea of a CVI ecosystem and being partnered with other evaluations. We kind of know that if there's good research that if people aren't intentional about it, and they just say, hey, there's a gun buyback down at the police station next Sunday, come on in. And, what you end up getting is people that are turning in guns that, got handed down from a family member that they never wanted in the first place. And you're not getting guns off the street that will later be used in crime. Having said that, when you combine it with this, other programs such as green space or violence intervention programs, then you may be getting them out of potential, guns that will be involved in crime. So I was telling Jim just yesterday when we were talking about this, I started a violence intervention program down in Maryland called the Capital Region Violence Intervention Program. And we had a client that was in the violence intervention program, carried firearms, right? And at some point in his recovery, he was like, you know what? I think I'm taking this to the next step. I got to get rid of this gun. And we were kind of at a loss of how to do it, right? Like, what's the best way of how to do this? And we actually got a pro bono legal opinion that came back and said, there's really not any good way of doing it. If you can turn it into the police legally, yes, but then it'll get fingerprinted if it's been involved in any crimes. And odds are it has been, and it's going to go back and that patient is going to feel as though they're in more danger. So you're probably better off just throwing it in the Anacostia River. The lawyer didn't say that, but that was the wink and nod. So my point is, there's clearly an evidence-informed way to do this, and linking it with some of these other ways, there's clearly a benefit. So, I'd put it in that evidence-informed way of putting in the ecosystem.
Yeah, no, I appreciate that, that point of view. So just to touch base on the gun buyback, and Jim knows this well, I was involved in gun buybacks for the last 12 years, and, we study them and get some anonymous surveys done where they're coming from, and access to firearms for kids, mental health issues, and suicide. And, we do find that folks who turn them in, have actually attempted suicide with some of the firearms. We do in Connecticut get some that have been involved with crime and do get turned in. Obviously, it's not the end all be all, but to actually look at it from a crime perspective, those guns that are turned in and not secured in those homes are prime setup to be used in a crime and be those homes robbed and those guns taken and put on the street. So I do see a purpose of it. And again, I think it's a multi-pronged approach, not a single approach that, we need to look at. But from the swords to plowshares, and it's actually I co-founded that. So I'm just, tossing in what are some of the metrics that we could assist with that program and helping to drive some of this home, because we were just down in DC presenting our program to Congress, to Rosa DeLauro and to Senator Blumenthal and others that are down in DC, and really they're very interested in this, and how do we look at it from, and I think you're spot on where I think some of it's eco point of view, but the actual transformation of guns into garden tools is really cathartic for people who have had some type of event that's happened in their life. So just something to add on that. And if there's something that you think we should be measuring, please let us know and we'll start doing that to help out this issue. So appreciate your talks and everything that you've brought forward.
Hey,
I would just
James and Cal. I'm sorry, go ahead, Cal.
I would just add, I think, especially if you're getting high client satisfaction, a lot of times in medicine.
Cal, if I could just interrupt just for a second, and I hope I'm not interfering with you prescribing maybe what the metrics might be, and maybe that's something we can discuss at another time, perhaps. If that's where you were going. If not, then I apologize. Please proceed, but I don't, want to.
Oh, I was just going to say, if the clients are finding satisfaction and reduction in trauma symptoms, then that's a very good metric, I think.
Mm-hmm.
Thank you. Okay. Any other questions? No other questions. Okay, Kyle and James, thanks again for your presentation and all the work that you guys have put into this, and I'm looking forward to the draft and then the additional revisions to the work that you guys have uncovered. All right, next up is the Policy and Funding Work Group, which is Carl Schitzel, Jeremy Stein, who will be presenting from this particular work group. And by the way, we want to acknowledge that Senator Moore has joined us. Okay, Jeremy and Carl.
Thanks, Andrew. Let me just share screen. Can everyone see that?
Mhm. Yes.
So first, I just want to thank all the hard work that my co-chairs, Carl Schissel from Connecticut Hospital Association, Jackie Santiago, poured into this. There's a lot of work that was done on this, and there's still a lot of work that needs to be done. And I want to also really thank Kyle and Jim for the amazing presentation they just gave, because I think it complements really well, what we're going to be discussing, which is to talk about the policy behind what a commission would look like, and also where that funding might come from and where that funding might go to. So, just to sort of table set, in Connecticut, there were 105 gun homicides in 2020, 91 gun homicides as of October 2021. The cities that are hit the hardest: Bridgeport, Hartford, New Haven, they had to account for 70% of the statewide total. In 2020, we saw very sharp increases in other cities as well, especially in places like Waterbury, which in 2020, I believe, was about a 500% increase in gun violence. And in 2019, the leading cause of violence-related injuries for teens and adults ages 15 to 34 was firearms homicide. That's more than motor vehicles. This is clearly a public health crisis that we are in, and it's something that we have to address. But we also need to focus on, who is most affected by that, and certainly the burden of gun violence falls disproportionately on communities of color. Nationally, Black males fall victim to firearm homicides nearly 17 times higher than white males. Approximately, when we look at the disproportional rate, specifically in Connecticut, it's quite alarming. Last time this was studied by the CDC, they were looking at populations. Only 10% of the state's population is Black, but accounted for 56% of the state's gun homicide victims. I know nationally that rate has gone up to almost 70%, and it probably has increased in Connecticut as well. Same thing with Latinx communities, make up 14% of the state population, but account for 23% of the victims in the state. So, obviously we have to be concentrating on where the violence is and who is most affected by this. And so when we're talking about the elements of a commission, there's a lot of elements that we should be putting into this. But first and foremost, as we heard from everyone on both of the public hearings, this should be a grant-making authority. The Commission on Gun Violence and Intervention and Prevention should be funding organizations that are doing the work. We need to determine community level needs by engaging with the community, which is what this advisory council has started to do. We need to secure state, federal, and other monies to provide stable funding. And these recommendations are that the state should be responsible for doing all of this. We need to establish a grant criteria, award grants, and guide the implementation of those grants, but also offer technical support and expertise to monitor these outcomes, to identify, study, and assess the efficacy of these potential community-based programs, which we just touched on some of the conversation between Pina and Kyle. And this also is something that needs to be staffed. It can't just be an ad hoc approach, or that we fund this when the next shooting happens, right? This should be a dedicated, funded, resourced commission, and there should be both a short-term and long-term strategy to this. It should be staffed with these resources from multi-disciplines, expertise, but we need to make sure that this is a stable long-term approach with budget line item funding, which I'll get to later in the presentation. And then also there should be an advisory council that is comprised of community stakeholders, public policy experts, gun violence prevention organizations, and others with a stake in the health of Connecticut's urban centers. So not only just communities, but we need also to have a wide variety of people to help make these decisions. We have a advisory council here, which we know is going to terminate by statute, but we do feel that that there should be a similar advisory council, maybe even broader members, to include research and others that will help guide this commission. And it's important to note that this this is not a new approach. So this is, excuse me, there. As Kyle had mentioned and Jim had mentioned, this is a very cost-effective approach. Gun violence in Connecticut, I think, costs about $1.2 billion per year, or excuse me, nationally. We're spending millions of dollars in Connecticut after the fact, whether it's on hospitals, on law enforcement, and we need to start spending preventative dollars and making sure that we are saving lives in the process. This is not a new approach. It's something that has been done across the nation. We've seen this in California, Colorado, Illinois, Massachusetts, Maryland, New Jersey, Pennsylvania, Virginia, and now Wisconsin, and the list is growing. Connecticut needs to be doing this as well. We are a leader on a lot of gun violence prevention. And honestly, I think this is some area where we are a little behind and we need to catch up. So, the main focus, as Jim and Kyle had touched on, and I'm glad they mentioned a lot of the organization that exists in Connecticut, but the idea is we need to fund not only, one approach, but multidisciplinary approaches to this, and really to look at this in three broad categories. We should be funding prevention, intervention, and aftercare. So it's not just one type of approach, but we should be looking at solutions that are going to be preventing the shootings from happening, which may be looking at root causes of gun violence, which is, solutions we heard from Greg Jackson at one of the calls, intervention strategies, which was spelled out in the prior presentation, but also aftercare, making sure that those who are affected by gun violence are getting those types of services, whether it's funeral or mental health or otherwise, because we know gun violence doesn't just affect the victims, it affects the families as well, and affects them for years to come. This is long-term trauma that we're talking about, much like any other public health or traumatic event that people would experience in their lives. The focus should be on people and places most at risk, as I mentioned in the earlier slides. Most of the gun violence occurs in cities and in specific neighborhoods in those cities, and so we should be focusing on that. We should be looking at data to find out where the gun violence is, and which I'll get to in a second, and to find out where those resources are. 40% of those shot are killed or injured again within 5 years. Some reduction strategies are related to the quality of life issues, and those include housing, education, mental health, jobs, resources, just to name a few. So it is important to make sure that we are coordinating efforts with other agencies that are doing that kind of work in those areas of housing, education, mental health, job, resources, reentry, to name some examples. When the three primary, as was mentioned earlier, three primary base models to look to support street level violence interruption models, hospital-based violence intervention, group violence intervention models, as we heard on the previous presentation. But the other thing that we need to be doing also when we're talking about evidence-based solutions is to find out, really looking hard evidence and to make sure that we're doing some sort of GIS mapping to find out where the shootings are, to find out, not just looking at gun deaths, but also looking at specific shootings and maybe look at shot spotter data. But we also need to do an overlay of services, like where are those services, where are those being provided, are they matching up with where the shootings are and where the services are most needed. And as Jim had mentioned, another overlay could be something in terms of vacant lots, or where is there need to be interventions in terms of blight or otherwise in these communities. So I think it would be interesting to look at where the shootings are and where those hotspots are and where where are those vacant areas that need to be developed. That could be a really cost-effective way to reduce gun violence. So it is important that we have researchers involved in this, or an epidemiologist, so that they can form where these services need to be. But we also need to be focusing on evidence-informed solutions. So when we talk about evidence-based, sometimes we're excluding some really amazing approaches to gun violence reduction, whether it's because the metrics just aren't right to evaluate them, or it's such a new approach, a novel approach, that we just don't have the data to support whether or not they're working. Some of these approaches we could see results in short term, but we may not see results for some approaches for years to come, and they may be very effective strategies that are working, but it may take a while to get the data and to study this. So we need to be supporting, innovative approaches, developing appropriate metrics that are going to measure success, but that are still objective, because we do need to measure what we're funding. We can't just continue to fund approaches without looking at whether or not this is an effective approach and whether or not it's working. So we do have to develop objective strategies for evaluating some of these funding organizations. But each community is unique, and it's not a one-size-fits-all, which is why it's important to have community approach to this as well. It is really essential to have the community continue to be involved even after the commission is formed. Technical assistance is going to be key to this as well. Assistance should be made available to organizations so that they can succeed. Grant assistance, so it's not just making the grants available, it's making the awareness of the grants known to organizations and making sure they know how to apply for grants, and they have the best chances of success to get those types of funding. Once again, getting research on the tail end as well as the front end, not just to look at where the shootings are, but to help organizations find those metrics and to make sure that we are, putting organizations in the best chance to showcase their success, and develop those appropriate strategies as we go forward. As I said earlier, an advisory council should be part of this. This advisory council should be comprised of community stakeholders, public policy experts, gun violence organizations, and otherwise. We can't address gun violence without, community gun violence without the community. So state coordination is really a huge part of this. I think initially we were thinking about adding some state agencies as a subcommittee, and it got tricky to have those state agencies on this advisory council. But there is a broad array of executive and judicial agency commissions and offices that have a role in gun violence intervention and prevention, along with individuals and various stakeholders. So the state should determine and implement the most expedient vehicle to consolidate existing services and as well as having the proper oversight and authority in order to make a seamless, coordinated, and integrated approach to this, right? So we have to, in order to achieve this system, there's got to be this coordination of efforts between the agencies that exist, and perhaps there could be other agencies that could be created as a result of this. But we have to look at efficiency, right? So that is going to be one of the biggest questions that we ask is, where does this live? There's going to be multiple approaches to this, whether it's in OPM or DPH or otherwise, but there has to be kind of this coordination amongst the agencies wherever it lives. There still has to be proper communication. One of the possibilities that had been discussed, the Department of Public Health had established in 1993 an Office of Injury Prevention, and just in terms of resources, that's something to look at as well as other state agencies to figure out where this best fits. So, Carl, do you want to hop in, or do you want me to keep going?
No, I think you're doing spectacularly well. Keep going, and
All right.
I really appreciate the effort. Thank you.
And Carl did a lot of work on the funding portion of this. We need to operate with existing. There's a lot of different approaches to this. How we do this, it could be some of these, it can be all of these, but I think this is, where we need to do some deep diving into how this is going to be funded. We can operate within existing appropriations. As I said, looking at existing agencies like OPM, DPH, Criminal Justice, Planning Division, and other agencies, looking at those existing appropriations, where this could is something that we'll need to do. We could reallocate existing appropriations, so we can look at how we're spending this money, and and this is where this kind of research and coordination and mapping out of not only just where the violence is, but where the service are is going to be really critical, because there may be funding going to one area or one type of organization, and we may need to look at consolidating efforts. But if the idea is to reallocate funding to make sure we're getting the most bang for the buck. But the idea, and I want to really make sure this point is made, is the idea is not to cut funding anyway. The idea is, to add funding, right? And because as I will get to, there is funding coming into the state, and both through Build Back Better and Break the Site, American Rescue Plan, there is funding that could help pay for some of the cost of this commission, but there's other funding streams as well. There could be the creation of specific allocations for this office through additional legislation or existing legislation. New general fund appropriation. We like in Connecticut to start with broader funding. The state could appropriate new and sufficient operating funds to sustain this commission through a line of general fund budget allocations. Use federal funds to sustain this is also something important, which I will elaborate on, but that's, as I mentioned, ARPA, Build Back Better, VOCA funds. And then there's existing programs, as Kyle did a tremendous job on his previous presentation a couple weeks ago, looking at Burn JAG, Project Safe Neighborhoods, VOCA, and Medicaid. We have a new Medicaid bill. So these funds have been expanded to allow the type of organizations they're talking about to get additional funding, and so that may be another avenue to look at. As we're looking at state level funding options, there's many different ways we can do this. First and foremost, the commission should be a grant source for funding groups engaged in prevention and intervention and aftercare, as I mentioned. So, and I think it is important that we look at those three categories as separate lines of funding, and not kind of group everybody together so that they're having to compete for funding when they may be doing completely different strategies. But if we look at it in terms of some groups may be doing preventative work, some may be doing intervention, and some may be doing aftercare. And I think there's kind of concentric circles in this. Some of those areas may overlap, as Jim had mentioned, with some of the hybrid models, but also some aftercare services really do end up being preventative services as well. We could establish a competitive state grant program for municipalities, so we could look at this as a city by city model, and cities could develop their own offices of gun violence prevention, and we can look, this commission can look to help fund those approaches as well. There could be targeted state grants to groups within a particular community who are identified at highest risk. We mentioned earlier about group violence intervention funding, such organizations as Project Longevity or Ceasefire, and then also state grant funding of hospital violence intervention programs through Medicaid. The idea is to kind of coordinate all of these efforts and make sure that what we're funding is optimized. And I'm going to steal a slide because I thought this slide was so good. This is Greg Jackson's slide from Community Justice Action Fund, and it does give a good overview of what federal funding is available. There is a significant amount of funding that may be coming into Connecticut, and some creative ways could be utilized to use this funding to support violence intervention strategies. We've seen cities use the American Rescue Plan funding. I think a good model to look at is New Haven, where they built this Office of Resilience, or they're building this Office of Community Resilience, and they're putting a lot of agencies under one roof: homelessness, reentry, data, and they're building an Office of Violence Prevention. And they're using federal funding to help and also state funding to help build this. But the idea is coordinated efforts to make sure that there's this holistic approach. So as Kyle mentioned, we hope that the break cycle of Build Back Better is passed. But there may be additional funding in Break the Cycle of Violence. That's a $6.5 billion bill. There are probably going to be additional strategies. There's also the actual federal budget, as well as congressional earmarks that we've seen to specific groups in the past. But once again, I think, in terms of congressional earmarks, I think it is important to have federal coordination as well to make sure those earmarks are dedicated to those groups that are, those funds are being used efficiently as well, and that the federal and the state coordination, there has to be a seamless coordination between the two. So with that, I will answer any questions. Carl, anything you want to add?
Yeah, thank you, Jeremy. I appreciate that. And just a perspective, those slides that sort of outlined how the commission ought to be funded. These are not intended to be mutually exclusive categories. And frankly, each one of the items on that slide are already in the Appropriations Committee and OPM playbooks. So we're not recommending anything unusual or strange. And in fact, on the funding of the commission slide, it is possible, because I know the question you always get in the money committees, appropriations and finance, are how you're going to pay for it. And one of the answers potentially that is not specifically included on the slide is the prospect of dedicating particular sources of state revenue to fund the programs in place. I recognize that we are in a general fund budgeting state, but with every rule comes an array of exceptions. These exceptions already exist in the state of Connecticut and other areas, and potentially could exist to fund this work. So those slides, particularly with respect to the funding of the commission and the suggestions about state level grant funding options, are just intended to be things that we think the commission ought to think about as it figures out how to sustain itself and how to achieve its mission. So thank you for the opportunity, Jeremy. I appreciate it. And it's been a pleasure working with you and Jackie and Andrew and Pina, in this area. Thank you.
Hey, thank you both, Carl and Jeremy, for the presentation. At this time, questions, input from our members. Okay, Carl Fisher raised his hand.
Yeah, I thank you, Jeremy and Carl. This is really helpful. The one question I have is, do you have parameters in mind for, guidelines for the grant making? So, one thing that, sometimes we see across the nation is policymakers, they give money and they want to see results immediately. And if, the world hasn't changed by next year, then people say, oh, this is a failure. We're not funding that anymore. It's clearly not realistic. So, we know in this field that longer term grants and, something that's a little bit more sustainable can be more effective. And I'm curious if you've added any notes on that in your plans for your report.
Yeah, I think the trick to this work, right? So our task is to advise on just the creation of the commission itself. And then once the commission is created, I think that is really an essential part of this, is what is that grant criteria? And I do think, Kyle, and I know you have experience with this as well, the model that a lot of states had used and cities had used as a starting point was, the CalVIT program, the California program. And, and it was, because it was so new, it wasn't without its challenges. And I think they have since, worked on trying to create an appropriate grant criteria that really works to help fund the community without making it too hard for those community groups to get it. So I do think that is a really important point, and that is going to be some of the hard work that the commission will have to do. But I think that is why you need this advisory council to be part of it. Going forward, whatever that grant criteria is, there has to be a community element, because there has to be input from those people and organizations that are going to be most affected by this funding, and to make sure that we are looking at innovative strategies, both evidence-based and evidence-informed, so that that groups are getting funding, but that it's not, the grant criteria isn't so hard to that the groups are doing this work now get cut out of the process. But and then also you have to make sure that it isn't so competitive that organizations that should be working together aren't now competing against each other for funding. And so if you appropriate properly and get state level funding for this, I think you can eliminate that kind of competition. There'll be more money there'll be plenty of money to go around if done properly.
Thank you.
Hey, any other comments, any other feedback? Mike?
Well, it's not on this. I'll after anyone has any questions, will either you or Pina allow me to share 2 slides on substance use in homicide victims?
Not at this. Actually, I'm sorry. Are you referring to your presentation that you'll be doing with the community engagement work group? Or is this
Yeah. That I sent you this morning.
Yeah.
If you.
Oh, that's fine. If I understand you correctly, you're looking at incorporating that into your presentation with you and Ms. Davis.
Yes.
Okay, that's fine. That's fine. Absolutely. That wouldn't be a problem.
Okay.
Sure. Okay. Any other questions regarding the presentation from Jeremy and Carl? All right, hearing none. Okay, Carl, Jeremy, thanks again. I'm looking forward to the initial draft and additional content that will be added to your report. All right, up next, we have the Community Engagement and Public Health Work Group, led by Ms. Deborah Davis and Mike Makowski.
Mike, is it okay if I just go first? Would that be?
Sure, certainly.
Okay, beautiful, wonderful. Okay, so I will send a PowerPoint a little later. I have a written document, but I'll send it in a PowerPoint a little later. Thank you so much. And thank you, Senator Moore, as well. And on our committee, Dawn Spearman, Ebony Epps, and Mike Makowski. And so it was a pleasure working with them and talking about the real ills of our community at large and across this country. And so I absolutely want to thank them for all of their incredible input. Our approach on the community engagement in conjunction with the public health department absolutely had to begin at the systemic level. So our approach, obviously, in thinking about that, this entire process, it had to include the absence of so many ills of the community to be addressed in order for us to begin. And so with that point, I want to just take 1 second and just probably a minute and go down the list of all of the agencies that is so important to work in tandem with public health because of what we're working with on an ongoing basis. And I believe it definitely starts at home. So let's talk about the environment. And one of the things that we talked about every time we had a session was the environment. Individuals living in an environment that is not conducive. There are environmental problems. There are problems with their conditions of living. And so coming into that setting of housing and urban development, we need to connect. We need to have a process where we can connect public health with our HUD folks so that we can begin to build and rebuild some of the housing areas that has been dilapidated. This is all systemic. So for us, the community risk factors were really important. The Department of Justice had conducted some research on how the community risk factors have such an impact on our youth, specifically in preventing crime. So the community risk factors in the housing area really basically sets that whole stage where that individual is living, not where they need to live in order to be safe, in order to have a healthy environment. So the next area, of course, is schools. There's so many risk factors with the schools. We have the potential dropout. We have the educational system that we need to tie into all of the work that we're doing. We can talk about prevention, we can talk about intervention, but our group know for firsthand that if we're not dealing and looking at this entire process from the perspective of making sure that we can address some of the ills of the community that are all systemic, we will be back at square one. So one of the things that the community engagement folks know firsthand, that the environmental department, the HUD, educational, our school system is really important. We have lack of resources, Department of Children and Family Services. Those individuals need to be tied in as well, because there's major mental health, individuals not having their mental health addressed. So we're already at the level playing field, it's not there. It's not there. So we're talking about prevention in our group, but we're talking about how we can make sure that when the community is engaged, how effective can they be when they're also working with this backdrop of all of these other factors that have plagued our communities day by day, economic development, all of those issues that continue to plague the community where we work and where all of our families live. So one of the key areas that we focused on is how do we begin as well to address some of these ills so that we can prevent our young people from potentially feeling as if they're on the outside looking in and having what we call most often, it's jealousy, all of these kinds of things that these individuals come out with. Their mental health not being addressed, not staying in school. The school dropout rate is definitely tied into that. We talked about all of those areas where we know that it would have an impact with our young people. This is totally separate of drugs, because drugs in our community, to the contrary, are not sometimes self-medicating. There is a way of survival. So we have to address all of those areas where individuals have not had access to. And so from our perspective, from the community engagement side, we want to make certain that we consult with these community outreach organizations, but victims as well, so that they can give us the specific input, which we've gotten through this last public hearing, which was an excellent public hearing, by the way, and identify the ways that they can provide some collaborative effort. So we're not talking about individuals doing the actual work. We're talking about coming together on a collaborative effort, talking about making and creating a participatory style as it relates to community engagement, and not one or two people indicating what should be done and what should not be done. Bridgeport is a different scenario. New Haven is a different scenario. That's why we need Ebony. That's why we need Dawn. That's why we need folks up here in Hartford. We need to take every perspective into view and look at it from the perspective of what they actually are needing. And that entire list obviously can go on and on, but we focused on how do we make sure that all of these ills are somehow addressed so that we can start to prevent. And that was the key area. So the community engagement platform will focus on several strategies. The consulting strategies, where we start to consult with individuals and then collaborate. And then one of the things that we do at Mothers United Against Violence, we actually try to empower those mothers. Yes, we can listen to individuals that are part of this commission. We can listen to other individuals that are outside of the commission, but they have to be empowered, because if we believe that individuals are empowered, they can have a stake as they are a larger stakeholder than anyone else sitting on this commission. They basically they have to empower themselves to use their voice so that they can help to prevent one child at a time from making a major mistake. That was really key for us. And we wanted the process to be inclusive of them. And as I spoke earlier, it should be bottom up. We should be listening to them on an ongoing basis. There should be a collaborative meeting or collaborative group sessions on an ongoing basis to get the temperature and the thermometer reading of the individuals that are living in the community. We have so many other areas that we know that are key ingredients in making certain that we help to prevent our young people from actually making that major mistake. The criminal justice system is another element that we know as individuals from the community and as part of the community engagement, having to interact with them as well, because we understand that there's the juvenile prevention and that delinquent models that they are actually now recreating in the city of Hartford. I know they have one in New Britain. They have one all over the state. And we want to make sure that we're looking at that as well, because one of the individual comments that I've heard from mothers is that, and from individual families, they've said that they do not have that middle of that gap. They do not have access to that gap if they're trying to get their child into a program where they can actually do some mediation with that child, where they can, they don't have that. The police is the police. That's what they do. Okay. And then there's no in-between system of where a mother or a father is trying to provide the support. They can't provide the support to the next level because that particular area is lacking. It's lacking. And so we've heard that very, very often across the board from the community engagement side, but we need to create a platform for an ongoing, consistent engagement with individuals from the community at large. And there were so many groups on there. We absolutely really felt like everyone was sending the same message: inclusive. And so for the community, it's the school family, individual peer risk factors for each community. And they are all over, from the educational side, from the health side. That includes the hospital. That includes what do they have access to in their community? What grocery stores, what individual food source do they have? All of those things, do they have access to those things? And is it really, really, really good sources of food? As you know, parts of Hartford is a food desert, which is incredible. So we talked about all those things, not having the access to. Mike just mentioned earlier, what does zoning have? Well, we just had to go before, this is another part of the community engagement, to make sure that there are no firearm stores in your community, where they put package stores on an ongoing basis, and where they create the environment where you have these young people and these individuals actually accessing. So yes, we can become dumping grounds. I know we can become dumping grounds because I understand economic development. I understand you can have a hospital in your location that is actually providing access to individuals that are recovering drug addicts, okay? And they can walk right in your neighborhood. And even if you go towards the city council, and I've had this from moms, they are not listening sometimes. We can become, and that was one of their issues. And I wanted to make sure that I made certain that all of those areas were talked about, that we want to make sure, not just the environmental component, we want to make sure that where these individuals are living housing conditions, we want to make sure that they do have proper access to actual health areas. We want to make sure that they do have good health care. And it's not just it's not just post-pandemic, it's throughout. And we've had that. So that's why one of the areas that we definitely explored initially was the actual systemic. Everything was systemic. And now we're finally working towards dealing with gun violence, which has been systemic in our urban neighborhoods for over 25, 30 years. And so one of the areas and that I know is important as we start to engage the community from the public health side, and Mike and I have talked about it extensively, is that we have to include all of the other ill factors of our community that we live in order to create better scenarios, better backdrops, if you will, better living conditions, better schools, more information as it relates to the size of classrooms. These are all rooted in to this dysfunctional areas. This is all rooted in. And that's what we realize, not just as parents, but as individuals living in the community and having to communicate with different levels of everyone. There's mental health issues consistently. And so we want to make sure that we keep that temperature reading and that heartbeat on with all of our families and all of our families across the board, Bridgeport, New Haven, Waterbury, New Britain, Stanford, all of those locations. We want to make sure that they have access to this process and they understand how important it is, and you understand how important it is as a commission, how important it is to make sure that we factor in all of those very, very important issues. And those elements, and as it relates to all of the ills of our community and how we create that public engagement and how we look at organizations, and we've talked to all these organizations that are doing this work already and how they truly believe that their work is just as effective as anyone else's, and how we understand how important it is to make sure that we hone in on their voice and giving them a voice. And that's really key. And with the relationship that we've developed with public health, we will be able to provide that backdrop in terms of statistics as it relates to those other areas that no one talked about. No one talked about lack of educational resources, overpopulated classrooms. No one talked about the environmental factor, which was major mental health. We talked a little about that in the beginning, but that's key. That is very key for these communities to even survive. So we want to make sure on the ground level that those areas, as part of our public engagement and working with public health and making sure that we can get more information as it relates to all of these organizations working together, it's really, really important. And if we start there, all of the committee members agreed that it's important that we address our own community with all of the other areas that are systemic, and then moving into the next level as well, but making sure that you hear their voices. That was really key. We hear everybody's voices, but we want to make sure that the community at that level in terms of public engagement, which is probably the most critical part of any process. You can talk about where the money goes, you can talk about different models, but you have to really address what some of the issues are. And that's where we come in, because we can work with public health, we can work with HUD, we can work with the educational system, we can work with all these folks to provide what they need to provide in order for us to help these specific communities. And we know where the shootings are, we know where gun violence occurs, we know that. And that's where we need to do our research as well. That's where we need to make certain that we are armored up and that we do not wait for the next shooting and the next homicide. But this is all on the prevention side for the community, for the engagement and working with the public health department, which is really, really key for us. So we want to maximize our efforts and our resources in effectively reducing the level of gun violence and the risks in the community. So we look at the risk, and then we want to provide some additional data that would demonstrate that that's where a lot of our individuals that are committing these homicides are absolutely coming from. And then we want to strengthen the ability to track the crime prevention program effectiveness as well. We want to promote the process of institutionalizing prevention in the community, and then place the responsibility for health and behavior problems on identifiable risk factors, not on people. And that's what we have been guilty of. it's the risk factors, not on people. The risk factors are there. They've always had Band-Aids and they've never been resolved. They've never been addressed. So we have to begin there from the community engagement, working with public health and other entities that can help provide the support in that area. And crime and violence prevention is really key for our group. So we want to be on the front line as well. And as I said, in order to create the platform, we want to have a way to communicate with them through both the visual, through the internet, through participatory collaboratives that we can do on an ongoing basis throughout the state, coming together as groups throughout the state, and not just at a vigil or not on a specific occasion, just coming together to make sure we're hearing the voices. And this is where our emphasis was in terms of helping to create a good strategy and an effective strategy that would absolutely provide some prevention. But first, we have to address a lot of the ills of our communities that we live in. And now I think I am, any questions? And I think I'm going to yield the floor to Mike.
Hey, Mike, I think you're unmuted.
Oh, he's muted. Okay.
Let me see if I can share my screen. So let's go to files. Oh no, it's not going to be there. Let's see if I can find it here. TJ, do you have the 2 slides that I sent to Andrew and Pina? Can you put them up?
I have them for you in a second for you.
I have 2 slides here, so I'll keep it brief. You know, as Deborah mentioned, you know, my concern about mental health in communities where trauma takes place. So I took an update. I looked at the current data as of September 30th, and the positive marijuana results have been increasing in homicide victims from 2015 to 2019. At that time, you know, 3 out of 10 homicide victims tested positive. During the pandemic, that number has gone up to nearly half, 5 out of 10. Also, you know, we have a concern about homicide victims dying from gunshot wounds in from 2015 to 2019. That number was about 41% or 40 in 100 during that time period. During the pandemic, it went way up to nearly 3/4, 74% of the gunshot victims test positive for marijuana. And I guess I'm paraphrasing a theory that, you know, when victims are under the influence of marijuana, they're impaired and they'll become vulnerable to perpetrators. And in some situations, you know, victims may become paranoid, aggressive and confrontational, which may add to, you know, their risk. And from last Wednesday's testimony from Damari in Hartford, that communities are self-medicating with marijuana, and it'd be interesting to know what other communities are self-medicating with marijuana. And the next slide is just a little update of the graphs that I presented from October 15th, and focusing on the by race, the rate of positive marijuana tests. And the blue line, Black non-Hispanic, we see from 2018 to where we are currently is the number has tremendously gone up. Thank you.
Okay.
Okay, I want to thank Deborah and Mike for your presentations. At this time, I want to open it up for any questions, any input. All right, Peanut.
Mr. Woods, do you mind if I ask a question? I'm sorry.
Yes.
Just one clarifying question for Mike regarding the cannabis use issue. Is there data? I don't know the data in cannabis use associated with the act of violence, but if you're saying victimization is one thing, that's documented in young adulthood and suicidality, but it's a loose correlation. Is there other data that you have that you'd like to share or that you can send us for review?
Certainly, there's a paper that I do have. It's not a case control study, so there's no causation, but it is a correlation that, people under the influence are more vulnerable.
And I understand that is a correlation. We just have to be very cautious about using the evidence in the right way, because if we start ascribing the responsibility of violence to cannabis, we also wind up risking a lot of race-related correlation that is not necessarily so. We have to be very cautious of that sort of material. So I'd love to see what you have, and by all means send it. I'll put my email address in the chat because I'd love to see it.
Certainly.
Thank you.
I just wanted to add one thing to that, and we're strong believers that the cannabis area does not necessarily make them more violent. So I'm definitely not a believer in that. But if you look at the numbers across the board in terms of people, the overdose number on fentanyl and all of those other areas, and that's what we wanted to look at as well. Because our communities deal with a combination of everything, we are gonna look at that as a total picture, because there are people of all ethnicities that definitely should be included. And in some neighborhoods, specifically in the North End, I know we have a clinic that is specifically for individuals that are fentanyl victims, and people are not totally knowing, what's going to happen next, because they absolutely are moving through. And this is everyone. This is a combination of everyone. And so this is another area that we talked about in terms of the environmental component of it and the environment that individuals live in. So I just wanted to add that.
Thank you.
I'm sorry. And just one last small comment is, I'll add to respond to Deborah. I agree with you. I think it's an important thing to consider. There's also a pattern of testing that is important in hospital levels. That when a person is killed and the ME can examine things in one way, that's far more thorough than the hospitals can. So the hospitals don't routinely, they do routinely test for certain things, but they also routinely test for certain things with a very high bias towards people who are Black or brown. And what we can't do is make sure that assumption is focused on, we have to make sure that assumption is made based on those people. I want to make sure we protect the population. Thank you.
I agree with that. Yeah, definitely. I agree. Certain.
Okay, thank you, folks. Jeremy, followed by Kyle.
Thank you, Andrew. And thank you, Dr. Shapiro, for your comments and your questions. Mike, I have a question. Has the Department of Public Health looked at any other, do you have any other data that looks at causes of gun violence, whether, it's looking at, education or like reentry or job programs, or perhaps the availability of mental health programs in a similar way that you had looked at marijuana?
There's other criteria. Certainly, they mention. Let me think. So maybe educational attainment. So a social economic side of things. And from our data that we get in the violent death reporting system, our surrogates, if you will, would be level of education and perhaps occupation. So you would have to make deductions based on that, but we wouldn't have like income. But certainly that plays a role too, socioeconomic status, in addition to mental health, the area you live in. There's multiple factors that all play in.
We're going to add some additional slides and information because there were some additional items that we did have. So I want to make sure that they're included in our presentation.
Thank you. Kyle Fisher.
Thanks. I'll just be real brief because I feel like the comments before me have kind of landed there. But I agree. I think this data point on the cannabis use indicates that there's a group of patients that need more, right? Like we need more to help out with social services and addiction and mental health. And, it's clear that that's an indicator for folks that need help. But like Dr. Shapiro said, that urine drug screen results are highly biased and they're really unreliable. I'll just only add, I'm working on a paper looking at fentanyl use in trauma patients and did a whole review of all sorts of drugs and what their effect on violence is. And, the data is fairly clear that of the different varieties of substances, stimulants, so things like methamphetamine and cocaine, may be a little bit more of a risk factor for people engaging in violence. Alcohol is a strong risk factor for violence. But some of the other classes, like cannabis, aren't really a risk factor for people being violent. But we do know that victims use substances to self-treat, like we mentioned. So I think thinking through the lens of this is a marker of something we should use to ensure patients have full mental and social services is probably the best way to interpret that.
Thank you, Cal. Any other questions? Any other input for the community engagement and public health work group? Seeing none, once, twice.
I think Dawn has a question. Andrew, I'm sorry. I think Dawn has a question. She has a comment.
Okay.
She's muted. I think she's muted.
I don't see her hand or her, she's still muted.
She's muted. Okay, maybe she can't come in. Okay, that's fine.
Okay. All right. Okay. Well, thank you, Deborah. Thank you, Mike, for your presentations. And again, we look forward to your report and your initial findings and recommendations. Okay. At this time, folks, we just a few reminders of our next upcoming meeting, which is Tuesday, November 23rd from 10 to 12. And again, Friday the 10th, and then Wednesday the 22nd for the final presentation, etc. And so at this time, we will conclude the meeting. And
Andrew?
oh, yes.
Yep, I just want to remind folks that we would like your written updates to us by December 3rd, based on questions that were asked to you today and any comments that were made. If you can incorporate them into your talks and get them to me by 3 p.m. December 3rd would be greatly appreciated.
Okay.
Hello?
Oh, it's Dawn. Yes.
I'm sorry, I touched the phone and it went off and I was trying to get back on. I just wanted to speak a little bit when they were talking about basically a lot of the gun violence in talking and in terms of, you know, being lack of jobs and different things like that. I think what I see more with the cannabis and different things, excuse me, with the cannabis and different things, it starts when they're younger and it starts from school, excuse me, at work as usual. It starts from, you know, them come from being younger ages. They come from actually getting out of school, being, most of our kids are, what is it? They're being diagnosed with ADHD. Okay, once they're diagnosed with this ADHD and different things like this, they start to drift off of being medicated from the ADHD and they go to the cannabis. Okay, I'm not saying that this is what's causing the death or in different things like that, but it's pretty much of what Ms. Davis was saying. It's a repeat on what's going on with the system. It has nothing to do with jobs. Yes, we do need jobs, but we have programs in the city that are trying to help people with jobs. But if you don't have an education to fulfill, or you couldn't finish going to school, you can't maintain the job. So it's not that you don't have a job that's making you kill. We have things. We have Project Longevity. We have a lot of programs coming in to help with finding jobs. But if we can't get through elementary to high school to learn how to go into a job, we can't keep a job. So it's not that we don't have that access. We have the access to the job. It's more so of what we need as far as our children and going back, starting at home. And that's all I had to say.
Hey, thank you very much, Dawn. Appreciate it. Okay. Folks, it's been a full 2 hours, and thanks again for everyone's hard work, and I'm looking forward to additional, again, data and information in your reports. At this time, I want to conclude the meeting, and happy Thanksgiving to everyone.
Happy Thanksgiving. Stay safe.